Okay, well, welcome everybody to this community webinar to update you all on Vamorolone. And this really is quite a profound moment for families in the UK because it's the first time that we've had a new treatment approved for all patients with Duchenne muscular dystrophy, regardless of their genetic mutation. And the development of Vamorolone really has been a global effort, mainly funded not by pharma, but by government money and by charity money. And this is a particularly poignant webinar for me and for my co-founder Alex, who sadly can't be here, because we actually funded the phase 1 study of Vamorolone back in 2015. So it's incredible to see the drug go through the development process and now be an approved treatment and available to patients in the UK. So I'm going to hand over to Michaela Guglieri, who's going to kick off the webinar. We're also lucky enough to be joined by Anne-Marie Childs, Tracy Willis and Jared Wong, who are going to be covering various elements of Vamorolone. And there will be time for questions at the end. So please do post your questions and we will collate them and ask the experts. We'll also be hearing from representatives from Action Duchenne and MD UK. So I will now hand over to you, Michaela.
Thank you, Emily. It's a pleasure to be here and to present Vamorolone, really thinking about what we know about Vamorolone so far and what are the implications now that we will soon be able to prescribe a new drug in clinical practice. So the webinar today, as Emily mentioned, will be led by 4 clinicians that has been involved in the development of Vamorolone. And we will go through briefly a summary of the evidence. So what do we know about Vamorolone in Duchenne muscular dystrophy so far, which I will cover. And then Jared will cover the management of side effects related to corticosteroids, specifically focusing on adrenal suppression, and Child will go into the practicality of prescribing Vamorolone in clinical practice with some clinical cases, and Tracy Willis will complete before the question with a summary of what we discussed. Next slide. So Vamorolone in January 2025, Vamorolone has been approved by NICE for the treatment of Duchenne muscular dystrophy. And based on the indication from NICE, is proposed as an alternative to classical corticosteroid for all children age 4 and above. And for a NICE recommendation, there is no specific limit in terms of upper age or functional status. Because the drug has been approved by NICE in January, each site has up to 90 days to implement it in clinical practice. And therefore, we are working towards having been in a position to prescribe Vamorolone in clinic from April this year. We will talk through about Vamorolone as Vamorolone, but we can also hear about AGAM3, which is the trade name. But throughout this presentation, we will talk about Vamorolone. The first thing that I want to point out is that Vamorolone is a steroid. And this is an important message. So it's not something that is different than classical corticosteroid in terms of some of the molecular aspects. It's very similar, remain a steroid similar to prednisolone or the Deflazacort. However, it has been designed in order to maintain the benefit that is predominantly related to anti-inflammatory effect of classical corticosteroid, but presented with fewer side effects. Next slide. What we know about Vamorolone so far in Duchenne muscular dystrophy predominantly come from 2 clinical trials. One is a phase 2A study, which was then followed up by an extension study and a long-term extension study, where young children between the age of 4 and 6 were treated with different doses of oral Vamorolone up to 30 months. And 48 boys were enrolled in this study. The second study is the phase 2B study, or 004, or Vision DMD study, and this was the pivotal study. So it's a double-blind, placebo-controlled study where Vamorolone, 2 doses of Vamorolone, 2 milligrams and 6 milligrams, were compared to daily prednisone and placebo. Also, this study enrolled children between the age of 4 and 6 and treated children for 24 weeks. And after 24 weeks, all boys were treated with either 2 or 6 milligrams of Vamorolone. The study enrolled 121 boys. So for me, it's important here to highlight that the evidence that we have so far about Vamorolone come only from a prescription of daily Vamorolone, and for the study that has been run only in young children, which started Vamorolone as a first corticosteroid at the age of between the age of 4 and 6. Next slide. How do we measure the effect of Vamorolone on motor function? Is using motor function tests, which are overall commonly to you probably because are routinely done most of them are routinely done in clinical practice. Is the time to stand, the time to run or walk 10 meters, the time to climb 4 stairs, the North Star ambulatory assessment, and the 6 minutes walking test. Next slide. So what do we know in terms of the effect of Vamorolone in Duchenne muscular dystrophy? We know that boys with DMD treated with daily Vamorolone did better on all the motor function tests compared to boys that were with DMD that in the study were treated with placebo, so were not treated with corticosteroid. And this is the one of the common functional tests that is the time to stand. As you can see, the boys that were treated with 6 milligrams of Vamorolone improve over the first 24 weeks, when the boys on placebo remain stable or show a slight deterioration. Next slide. But when we compare Vamorolone with daily classical corticosteroid, what do we know? Daily Vamorolone shows similar effects on motor function test to classic corticosteroid. And this was demonstrated against daily prednisone up to 24 weeks. And it was demonstrated also against natural history data, so a group of boys that were treated with different corticosteroid regimen and different type of corticosteroid over a period of 30 months. So up to 30 months shows similar effect. When we compare to different doses, up to 48 weeks, daily Vamorolone at the dose of 6 milligrams was more effective than the 2 milligrams per kilo per day. Next slide. So what do we need to remember in terms of the efficacy is that for the information that we have so far from clinical trial, Vamorolone has only been tested in young boys that are still able to walk and were treated for a relatively short period of time, after 30 months. So far, we do not have a direct comparison in terms of the effectiveness of Vamorolone versus the Deflazacort or versus intermittent regimens. And the last thing is that for what we know so far, and it's partly related to the fact that the study were relatively short in terms of the duration, we have information about the effect of Vamorolone on motor function test. But still, we do not have information about the effect on the heart or on the breathing, because these tests require more time. We now move into the assessing the safety. So what is the side effects profile of Vamorolone versus classic corticosteroid? What the study have shown is that boys on daily Vamorolone did not show a slowing of growth. In this case is the blue line that you can see in this graph. When the slowing of growth was observed in boys treated with daily prednisone, as we expect for what we know about classic corticosteroids. So they show a slowing of the growth. The boys who, after 6 months on prednisone, switched to Vamorolone, they showed that they started to catch up with growth. But to highlight that these boys were exposed to prednisone only for 6 months. Next slide. We also know from the study that daily Vamorolone was associated with similar weight gain and increase in body mass index or BMI compared to daily prednisone. Next slide. And this finding in terms of the effect on height and weight was also confirmed in the longer comparison with natural history data up to 30 months. So also up to 30 months, the boys on Vamorolone did not show a slowing of growth, which actually is reported with prednisone or other classic corticosteroid, but show a similar effect up to 30 months on BMI and weight gain. Next slide. Considering other side effects, in terms particularly on bone health, what we know is that vertebral fractures were less frequent in boys treated with daily Vamorolone compared to boys treated with daily corticosteroid, either prednisone or deflazacort. But it's also, I want to point out that also boys on vamorolone has a higher frequency of vertebral fracture compared to boys that were not receiving corticosteroid or were treated with prednisone 10 days on, 10 days off. This data has not been published, but has only been presented in conferences. From the early evidence, it seems also that vamorolone might be associated with fewer behavioral problems compared to prednisolone, but these data need further analysis. Next slide. We also know that vamorolone causes adrenal suppression, and I don't add more on this because Jared will cover this in more detail in the next presentation. So as a take-home message in terms of the safety, again, we need to consider that the study also for the side effects profile come from young children and for over a short period of time, which means that we do not have information on several side effects that we know being associated with classic corticosteroid, but that often require more time to exposure to the drug in order to manifest. And again, similarly, we do not have evidences in terms of the comparison with the deflazacort or intermittent regimen, specifically regarding weight gain and behavior. Next slide. There is a lot of unknown in terms of evidences in terms of the long term, but this is the list of upcoming studies or programs that are ongoing using vamorolone in different settings, and hopefully will provide in the coming year more information about the long-term effect of vamorolone in DMD and in other age group or other patient that might not be ambulant anymore. Next slide. And I think that this, I pass it to Jared.
Thanks, Michaela. Next slide, please. So Michaela has discussed some of the side effects that we see with vamorolone, and Michaela has already introduced the concept that vamorolone is a steroid, and the data currently shows that similar to classic corticosteroids, vamorolone causes adrenal insufficiency or adrenal suppression at 6 milligrams per kilogram, similar to prednisolone. And this is data from the clinical trial, which shows that boys who were treated with prednisolone, 92% showed adrenal suppression after 48 weeks of treatment. And with vamorolone, 6 milligrams per kilogram, very similar data shows suppression of the adrenal gland. And remember, the adrenal gland are sleepy or suppressed due to the high dosage of these steroids, either prednisolone, deflazacort, or vamorolone. It switches the signal at the level of the pituitary gland and stops the adrenal glands from making sufficient steroids. And if that happens in the context of high-dose steroid treatment, i.e. with prednisolone or vamorolone, the dose is high enough to keep the boys healthy and well on a day-to-day basis. We do, however, know that vamorolone at 2 milligrams per kilogram, which Michaela says is not as effective for muscle, seems to be only associated with adrenal insufficiency at about 50% of that. Now, of course, we know it's not as effective for muscle, but there lies a problem where 6 milligrams per kilogram causes adrenal suppression to the same degree as prednisolone, so boys can switch from prednisolone to vamorolone in a direct switch. But boys who are switched onto a lower dose of vamorolone, less than 4 milligrams per kilogram for whatever reason, or in fact who are heavier because the maximum dose of vamorolone is 240 milligrams, there might be an issue in terms of symptoms of adrenal insufficiency. So adrenal insufficiency happens with vamorolone, and it is important that boys starting on vamorolone or switched onto vamorolone continue to have their stress dose regimen. Next slide, please. So treatment doses of steroids, prednisolone or deflazacort used in Duchenne causes adrenal suppression or adrenal insufficiency. But like I say, the dose of prednisolone or deflazacort is sufficient for the boys to function well without stress on a day-to-day basis. Vamorolone used at 6 milligrams per kilogram causes adrenal suppression to the same degree. So when we're swapping boys from prednisolone or deflazacort to 6 milligrams per kilogram, we can swap these boys directly, but we have to be mindful that we might get symptoms, but we believe that this is a direct switch as possible. Next slide, please. However, if boys are swapped to less than 6 milligrams per kilogram, or boys who are much heavier, when swapping from prednisolone or deflazacort to the dose of vamorolone, there might not be sufficient steroid coverage from the point of view of the adrenal glands for those boys to feel well. Next slide, please. And in some of these boys, there might be symptoms of adrenal insufficiency, and this is a table listing some of these symptoms. Now, of course, some of these are very vague, and it can be in the context of other explained reasons, for example, a viral infection or anything like that. But if these symptoms are present within the first week or two of switching from steroids, i.e. prednisolone or deflazacort, to vamorolone, we may have to think of insufficient adrenal coverage, and there might actually need to be some other modes of treatment for that. So next slide, please. So the DMD Care UK Bone and Endocrine Working Group have developed a plan for safe switching of steroids, i.e. prednisolone and vamorolone, of deflazacort to vamorolone. We believe that boys who are switched to 6 milligrams per kilogram, or indeed are much lighter, i.e. less than 40 kilograms, a direct switch is possible. But if their symptoms, which the clinician believe are new and suggestive of adrenal insufficiency within the first 1 or 2 weeks, regular hydrocortisone tablets in addition to vamorolone may be needed. However, for boys who are much heavier than 40 kilograms or needing to go on to vamorolone at a lower dose than 6 milligrams per kilogram, for safe switching or transitioning, we are recommending that these boys take a short period of hydrocortisone tablets in addition to vamorolone, but also closely watching for symptoms of adrenal insufficiency. If symptoms are still present on hydrocortisone treatment in these boys, and if the clinician believes these are related to adrenal insufficiency, there may be a case to increase to higher doses of hydrocortisone, but these will be monitored by the clinician. So there are some considerations in terms of switching to vamorolone, particularly on heavier boys or boys who are transitioning to a lower dose, which your clinician will discuss that with you. Next slide, please. So monitoring of young people with DMD on vamorolone is similar to those in classic steroids. Steroid sick day plan is still needed. Michaela discussed that vertebral fractures are still present, although probably at slightly lower. So X-ray imaging or the bone density scan, height and weight check, and puberty check from the age of 12 is still needed, as we currently do not have any information on puberty. So I think that's my last slide.
Thanks, Jared. I'm going to just use some, and I have to say these are purely fictitious cases, to illustrate how things might work in the clinic setting, taking what we've heard from Michaela and Jared and trying to think about how we might apply that information. So first of all, we're going to look at a boy, Ben, who's just been diagnosed with DMD, and the plan is that he should commence steroids as per the standards of care. And the question is, which steroid should we start? And as you know, the options are vamorolone, deflazacort, or prednisolone. And they come in different preparations. We also need to think about which regime we might use, whether we might be looking at a daily regime or an intermittent regime. And as with every decision, there's always a balance between the benefits and the side effects of any intervention, but we've also got to think about other factors that might help us make that decision. So one of them is what we've just looked at. What's the clinical evidence, or what information have we got to support the discussion? What are the individual factors in that young person, and what are the family wishes and beliefs that are going to be really important in thinking about getting a balance right? Next slide, please. So in terms of this case, the evidence to support the decision is that we know that prednisolone and deflazacort are equally effective, and they have a similar risk of side effects, although albeit a slightly different profile. There's perhaps more height restriction with deflazacort and more impact on bone health, and prednisolone has a bigger effect on behavior and weight gain. Intermittent prednisolone, we know, has fewer side effects, but similarly, it's not as effective. We know that from the 4DMD study. And daily vamorolone, as you've just seen, at a dose of 6 milligrams per kilogram, also shows similar benefits to daily prednisolone, but there is evidence that height or growth is preserved and that there's some other potential benefits that we've talked about. So next slide. So let's imagine in this family are keen to start steroids. They're obviously understandably worried about the overall side effects, but they don't have any specific concerns. They've had the opportunity to read the information leaflets on steroids and the information provided about Vamorolone, which, as you know, is available through the DMD Care UK website. And they also feel that Ben would manage a liquid, but they are a little bit worried about whether he'd manage a daily tablet. And so the outcome in this situation might be that after this informed discussion about all the known effects and the options, making sure that the family understand about the uncertainties about the long-term effects of Vamorolone, but having been reassured that whatever decision they make, Ben will be monitored closely, and that the dose and type of steroids can be changed if it doesn't feel like this is in his best interest, if the balance isn't right for him. And at the end of the day, in this situation, the decision is to start Vamorolone at a dose of 6 milligrams per kilogram per day. I think it's safe to say there's never a right answer in these situations. Next one then. So let's take a different scenario. Imagine the case of Angus, who I've made up, who's 12, and he's been taking steroids for his DMD since 6 years of age. And Angus has a diagnosis of autistic spectrum condition, and parents have been very focused on thinking about the right education for him until the Vamorolone story came into their lives. Their main worry was getting his high school place right. They have been worried about the side effects of steroids, and therefore they've elected to use intermittent dosing with a 10-day off, 10-day on regime of prednisolone. And whilst he's been losing some motor skills, family are really worried about his behaviour, and they're worried about switching to daily dosing because they know and they see that his behaviour seems to be worse on the days on steroid, and therefore they wanted to discuss switching to Vamorolone. Next. So thinking about this scenario, what's the evidence to support the decision making here? Well, we don't have any clinical trial or indeed real world evidence about intermittent dosing with Vamorolone. We know that there's no evidence of clinical benefit or side effects on an intermittent dose. We also know that that lower dose in the clinical trial was much less effective in terms of motor benefits. But at the end of the day, intermittent dosing is not licensed by the MHRA, and it's not approved by NHS England. So it isn't something that we would be able to institute in the clinical setting in the UK. The other thing to think about here is that if behaviour is a big issue, then there is some evidence that deflazacort is perhaps better in terms of behaviour. And so in this situation, the options might be to look at switching to daily Vamorolone, staying on the intermittent prednisolone, switching to intermittent deflazacort, or switching to a daily dose of prednisolone or deflazacort. Next. So in terms of the discussion here, I think the family have thought about these things. They've made a decision a long time ago that they do not want to switch to a daily dose of steroids. Although they accept that the side effects of Vamorolone do appear more acceptable. Angus has got some issues with his sensory feeling when he's eating, and he preferred the idea of a tablet to taking a liquid medication. It's really important to review those known and unknown pieces of information on Vamorolone, and to just stress again that we don't really understand what the impact of switching to Vamorolone will be after 6 years of prednisone. Really important to be mindful about the issues about adrenal suppression that Jared's just highlighted, and worth looking through the data from 4DMD on deflazacort side effects. And in this situation, because of the family wishes, a decision was made to switch to intermittent deflazacort in the hope that might be better from a behavioural point of view. Next one. And my last case is Dan, and Dan is 15. He's been diagnosed with DMD at 4 years and has been on daily prednisolone from the age of 4, but switched to deflazacort about age 9 because of concerns about weight gain and height restriction. He currently weighs 65 kilograms, and his deflazacort dose works out at about 0.5 milligrams per kilogram per day, which is about half of the starting dose, a little bit more. He's still walking short distances, about 50 meters, but he uses a wheelchair for distance. In terms of side effects, he has got markedly restricted height. He's had moderate weight gain, and consequently his BMI is high. DEXA scan shows that he's got low bone density, and he's also got delayed puberty, but has been treated with testosterone. He had a fracture of his femur after a fall at 12 years of age, but worked really hard to get back on his feet and mobilize after that fracture. But he's read about Vamorolone, and he's read that Vamorolone perhaps is better in terms of growth and is very keen to switch. Next slide. So the evidence to support decision making here, well, again, we don't have any clinical trial or real world evidence about Vamorolone in teenagers. We don't know either what the motor benefits or the side effects are going to be. But in this case, because of Dan's weight, he's not going to be able to start on a 6 milligram per kilogram dose, and his dose at the maximum of 240 will work out around 3.7. We also don't have any data on equivalence. We don't know how to match your dose of Vamorolone with your dose of prednisolone or deflazacort. We do know that the clinical trials showed some recovery in restricted height, and you've seen that data after 6 months of treatment. But what is the impact going to be after 11 years of classical steroid treatment? We know that Vamorolone is not necessarily going to be helpful in terms of weight gain. There is a lower rate of vertebral fracture compared to daily prednisolone or deflazacort, and possibly some preservation of bone health. But we don't know whether this is going to result in a reduced fracture risk for Dan at 15. And we don't know whether there might be a benefit for him in terms of risk of scoliosis. But what we have is no data about the impact on puberty, cataracts, and the other adverse events we see in young adults. And there's obviously a little bit of a worry about what would happen in terms of his renal function. So the options really at this point were to think about switching to daily Vamorolone or staying on deflazacort. So next slide. And on further discussion, it's clear that Dan's really worried about his appearance. He feels anxious, he's got low self-esteem, and he doesn't feel very confident with his peers. He and his parents demonstrate on discussion that they really understand that there's no data comparing Vamorolone to deflazacort at all, that there's no data on Vamorolone use at this age or stage of the condition, and that there may not be a benefit in terms of his bone health or growth given his prolonged steroid use. They also know that the maximum dose he can take is lower than what would be recommended. And they know that he may be at risk of adrenal suppression during the switch. But despite that, decisions made that it's reasonable to switch to Vamorolone at that dose. But obviously, Dan's going to need fairly close monitoring and review. And if at 6 months, the feeling is that this has not been beneficial for him, then there's always the option to go back to his previous treatment. I'll pass to Tracy.
Thank you, Anne-Marie. Yes, so I'm going to present a case hypothetical of Sam, who's a 20-year-old young man. And he was diagnosed with Duchenne at 5 years of age and started steroids soon after and was on daily prednisolone. And he was very active in clinical trials and continues compassionate use on Ataluren. And he maintained his walking until 15 years of age and unfortunately became non-ambulant after a fracture, but continued on his daily prednisolone. But he was concerned when he was about 17 about his weight gain and cushingoid features and really wanted to try and reduce his steroid amount that he was on. But he was also aware that actually being on steroids also helped with his upper limb function and respiratory function. So this was done in a controlled fashion, and he reduced gradually the amount that he was on and got to a point where he felt that he was happy with both his appearance, but also his upper limb function was still maintained. During this period, he did have a couple of further fractures following wheelchair football, but was having regular bone protection and regular clinic appointments with the metabolic bone team in the adult clinics and having infusions of bisphosphonates. And he was quite happy with this. Next slide. Next slide. So he's currently now on prednisolone, 15 milligrams per day, but his weight is 80 kilos. He's a 20-year-old. But he's actually doing very well. He's got relatively good preserved heart function, and he's still not yet gone on to non-invasive ventilation. He has his emergency steroid plan in place and has his emergency hydrocortisone for sick day dosing and IM hydrocortisone. But he wanted to discuss that he'd heard about Vamorolone and wanted to look at whether or not this was something that he would think about doing, whether there was any benefits at his stage at switching, given that he felt that he was quite stable on his dose of prednisolone, which is a fairly smallish dose, but actually was still seeming to give some effect and protection. So similarly to Anne-Marie's cases, I think, there's no clinical trial or real world evidence with adults and the use of Vamorolone. There's no evidence particularly of clinical benefit regarding the side effects with patients who are post-pubertal, already in that stable phase and treated with bisphosphonates for their bone side of things. And obviously, one of the main issues that Sam wanted to discuss was the extra hydrocortisone cover and that possible protracted length of time that he would be on the hydrocortisone cover, as well as the Vamorolone and the weaning regime, as he would definitely be on less than 6 milligrams per kilo. So his options were to either switch to daily Vamorolone, and we would keep a very close eye on his adrenal function and any symptoms regarding that, and looking at his hydrocortisone sick day dosing. He would be starting on the maximum dose, but that would be about 3 milligrams per kilo given his weight. And as we've discussed before, he would need extra hydrocortisone cover in that weaning regime. Or he could stay on his low-dose prednisolone, which he'd been very stable with over the last sort of few years. And so the decision was, after he'd been given all this information and we'd looked through all the evidence, that he would actually stay on the low-dose prednisolone. But he had the option of thinking about switching to Vamorolone. So next slide, and I'll hand over to Michaela.
I will briefly present a different scenario that might interest some of you, that is about the impact of Vamorolone for a patient that are in clinical trial or might be considered for a clinical trial. Here is an hypothetical case of Elliot, who is an 8-year-old boy who is on daily prednisone since the age of 5 years. He has experienced some side effects of corticosteroid, particularly related to slowing of growth and behavior. Parents have heard about Vamorolone and are keen to consider to switch Elliot to Vamorolone, specifically regarding the potential benefit on height and behavior, but are also interested in clinical trials. In fact, Elliot has also been recently approached because he might be eligible for an interventional trial using antisense oligonucleotides. And the family has always been interested about the possibility for Elliot to also be considered for gene therapy treatment or gene therapy clinical trials. And therefore, in clinic, they have a lot of questions about what is the impact of considering Vamorolone on their potential enrollment in clinical trials. And particularly about if Elliot switched to Vamorolone, will he still be eligible for clinical trial? And if he's already in a clinical trial, can he switch to Vamorolone at some point? And what about gene therapy? And here I've just, obviously is an evolving field, so I don't have the answer of all these questions, but I think that in general, clinical trials are now becoming more open to patients continue to be enrolled in clinical trial if they are on Vamorolone. We need to consider that Vamorolone, as I mentioned at the beginning, is a steroid, and therefore when clinical trial required as an inclusion criteria to be on a stable corticosteroid regimen, these include Vamorolone. However, most of the clinical trials require to be on a stable corticosteroid type and regimen for at least 3 or 6 months before enrollment. And this would apply also to Vamorolone. So if someone starts Vamorolone or switch to Vamorolone, they are likely to need to wait for at least 3 or 6 months, depending on the clinical trial, before being considered for clinical trials. And usually clinical trials also require the boys to be on a stable corticosteroid type and regimen for the duration of the study. So while they will be allowed to take vamorolone for the duration of the study, for the duration usually of the placebo control phase, they will not be able to switch from classic corticosteroid to vamorolone or vice versa. So these are considerations that we need to start thinking about. And again, similar to the cases that have been presented so far, I don't think that there is one answer that is the right answer for everyone, but it's something else that needs to be considered. Next. And I think that is back to Tracy.
Thank you. Sorry, I was on mute. I think, as Emily said right at the beginning, I think this is a really, sort of important milestone that we've reached here with the treatment in Duchenne muscular dystrophy. And I think this, definitely is a positive step. And we've got a drug that, we now have comparison with our classical steroids, where we've got some definite improvement in the side effects, but still have that efficacy in the motor milestones that are so important for our young lads with Duchenne muscular dystrophy. So the take-home messages are that this is effective at 6 milligrams per kilo. We've seen this, and this is published in the clinical trials, that we've seen normal growth compared to the classical steroids, where otherwise there is slow growth and stunting of growth, and we've seen good evidence with regards to this. And we've got, evidence with the bone turnover markers that are improved compared to those that are on classical steroids. And we can see that, sort of has an effect on boys. And there is a lower risk of that spinal fracture compared to those that are on the daily prednisolone or deflazacort. However, there is still a risk of fractured with vertebral fractures compared to those that are on that intermittent regime of prednisolone. And this is data that has been presented. Next slide, please. Obviously, we've seen from the evidence tonight, and from what you've read in the that have been published, that obviously we still do see the side effects that we see with the classical steroids, prednisolone, deflazacort, with that similar weight gain compared to what we've seen with particularly prednisolone, and that is in the boys that are treated up to about 3 years. And the most important is that of the adrenal insufficiency, which is the same that we see in prednisolone. And I think particularly when we're switching over the boys from a classical regime over to vamorolone, this is particularly important, that we've got to bear this in mind. Look out for those features, but also make sure that you've got your steroid regime and 6-day dosing. And this is something that we will need to be really impress on all of our parents and our clinical teams to look out for. Next slide. So I think we've presented tonight a lot of the known and evidence data that we've seen, but as you can see from the cases that have been illustrated, there's also a lot that we don't know, and that's the problem. With clinical trials, they're fairly short, and we do come out with some positives, but there are the unknowns. And I think that's where we will benefit from continuing to collect data, as we do with all of our boys with Duchenne muscular dystrophy and with our adults, on what happens to them over time with regards to muscle strength and function, heart function, respiratory function, and bone health, as well as development and puberty, which we will be starting to see in those boys that were in the trials that are reaching those ages now. So I think it's really important that we have to be clear that, there isn't that evidence for the long-term effect on muscle that we know in those that are on classical steroid regimes. And therefore, we will be, looking and making sure that we're collecting data about this. And we don't know the impact on respiratory and cardiac function long-term. So I think these are really important things that we need to monitor and look at, and be quite clear with our families that, you know, whilst there are some things we know, there are a lot that we don't know, and that is the importance of collecting data. And that, you know, although Vamorolone has got some good side effect profiles, there are still some that are similar to those that are the classical steroids. And obviously that adrenal function is something we need to watch carefully. So I'm going to hand back over to Emily. Thank you.
Well, first of all, thank you all so much. There's a lot to digest here. It is complicated. And just to reiterate what you said, Tracy, we do have some data, but we don't have all the answers. But I do want to just say thank you to all of you for really thoughtful and well-explained presentations that I hope will answer some of the community's questions. So we've had quite a lot of questions in the chat. So the first one from Dr. Shaw, when do we hope to have more information regarding the impact on heart and respiratory function from further trials?
Maybe I can take on this one. There is currently only one clinical trial, that is the 006 study, which is a short-term study to explore the effect of Vamorolone in very young children, 2 to 4, and in older children, age 7 and above, that switch from classical steroid to Vamorolone. So there isn't a plan in terms of a clinical trial currently ongoing, might be in the future, to study the effect on respiratory and cardiac function. So these, I think that I highlight 2 points. First of all, I think that is important also to know that it's true that we do not know a lot about Vamorolone and the long-term effect. Remain a steroid, and the anti-inflammatory effect of Vamorolone has been demonstrated. So overall, I would expect that Vamorolone will show a similar efficacy on the respiratory cardiac function to classic corticosteroid based on the information that we have on the effect on skeletal muscles, on the muscle strength and function. But obviously, the demonstration of this will require us to collect data in the real world to evaluate the long-term benefit and side effect profile of Vamorolone. And here I want to highlight the importance where in clinic we will continue to collect the data through the North Star, and the importance to put together these data to really answer some of, being able and be in the position to answer some of these questions in the future. There is one component that we have not touched today that I think that is important, however, is another things to put on the table, is that Vamorolone has a slightly different effect on the mineral corticoid function. So there is the potential that Vamorolone could protect the heart similar or even more than classic steroid, but could also interact with cardiac medications such as eplerenone and spironolactone. So there are some monitoring that will be recommended from a clinical point of view to monitor these aspects.
Thanks, Michaela. All other experts feel free to jump in, but there's another question about Cushingoid. Is the Cushingoid risk similar with Vamorolone compared to deflazacort or prednisolone? Do we know anything about this?
We know very little, and the reason of this is that the Cushingoid is also something that is subjective. So is how do we notice? In the long run is quite obvious, but in the clinical trials, such as the one that have been done so far, it's really a little bit the perception. And we need always to remember that the clinical trials are in different countries, in different cultural aspects, and therefore the reporting of such side effects is much, much more patchy than reporting of height and weight. So we do not have really clear information, which also means that probably there are some similarity. In clinical trial, they reported there is less reporting of Cushingoid as an adverse event in the Vamorolone treated compared, for example, to what we reported in the 4DMD. But how comparable these are is very difficult to say. So I think that there's a lot of unknown for that perspective. Probably similar.
Thank you, Michaela. Jared, there's a question here on bone. And the question is, what do we know about growth and bone density benefits for boys switching to Vamorolone after, let's say, 5 years on prednisolone or similar?
So as it stands, so hi, Dr. Shaw, by the way, that we currently do not have any published information of switching from classic steroids, especially for a couple of years. There is a small trial that is running in or almost completing in North America. Michaela can confirm, but we don't have results as yet. I'm not quite sure that there are actually bone density results from that trial. I'm not completely confirmed. But so really, I suppose just to highlight the point, we don't actually have any published information on switching from long-term steroids to vamorolone at this stage, but there's probably a very small clinical trial that we may see results soon. Michaela, I think that's correct, isn't it? Maybe you can.
Yeah, the problem is that the study that is ongoing, which includes some older boys and young men that switch after years of corticosteroid, is predominantly a short safety study. So the exposure to the drug in terms of the trial is very brief. So they will measure some element in the blood, so the bone biomarkers, so are testing the blood that tell us a little bit the effect on bone, but probably, again, we will need more time to have a clear evidence on that.
Thank you both so much. We've got a question from newly diagnosed. If the child hasn't started yet any corticosteroid treatment, would the recommendation be to start on vamorolone?
You want me to take that?
Yes,
I mean,
please,
I think that there's no right answer in this situation. So I think it really is really important to have a good discussion with your treating team and have a think about looking at the information that's available and then working out what feels like the right thing. I think it's a very reasonable thing to start on vamorolone. That's where we've got the most evidence in boys who haven't had steroids yet, and where we've seen that the benefits seem to be very similar to the boys who've started prednisolone, but we do see that the improvements in the growth and possibly behavior. So I think I suspect that that's where we'll see most vamorolone use in the short term in the UK. But you know, it might not feel like the right thing for some families, and people need to be encouraged to make what feels like the right decision for them once they've had the opportunity to have a really good chat with their treating team.
I might just flip that question on its head and say, what about if you start on the traditional steroids, prednisone or deflazacort, and then switch to vamorolone? There's a question here asking, is that more risky?
Well, I mean, in terms of I suppose what depends what you mean by risk. I think the most important risk in the short term would be what we discussed about the adrenal glands, and that would depend a little bit on how much steroid you'd been taking before and what dose of vamorolone you'd be able to go on to. So for a boy who can go on to 6 milligrams per kilogram, the risk seems to be relatively small, but it's something that we'd be monitoring and looking out for. But if you've got an older boy or a heavier boy who can't take that 6 milligram per kilogram dose, then the risk of a problem with the adrenal gland does seem to be a bit higher. In terms of risks, in terms of the wider spectrum, I mean, I think it's very difficult to know, but I think that none of these things are set in stone. So if somebody starts on one steroid and has had enough time on that steroid, or 3 of 6 months, to work out what's happening to them in terms of the short-term side effects, at least, and the benefits, that it's possible to change. Now, obviously, nobody wants to be flick-flacking from different medication every 3 to 6 months, because nobody will know what's going on then. It'd be very hard to work things out, because, as you know, when you're thinking about starting steroids in a young boy, there's so much going on. Often starting school, everyone's coming to terms with the diagnosis. Maybe there's a new little sibling in the house. There's so much going on that is going to impact things, that it's really important to try and give everyone a chance to work out what's doing what.
Can I just ask maybe one aspect for Jared maybe to clarify, is that obviously when we switch, there is the potential risk of the adrenal, especially related to the dose, but is this risk limited in time? And then we would assume that the body will adapt to the new, to vamorolone, or do you expect this to last?
I think So we don't really have very much. So just to clarify, there are some reports, particularly from the US, where vamorolone has been used for over a year, that in some boys who switched from steroids to vamorolone, there are some symptoms which could be seen with adrenal insufficiency, that could be attributable to adrenal insufficiency, like I say in that table. If we do see the symptoms, it will be in the short term. So we're not talking about, so for example, somebody's been on vamorolone for a year, they get some tiredness or some headache or some muscle aches. That is unlikely to be due to the switch. So those symptoms are over the short term, basically, when we're talking about, the first few weeks, generally. But it's an area we don't really know very much about. And I think we need to, get the feel.
There's a question here about taking vamorolone with another steroid from time to time. Could a mix be acceptable? I might ask that to Michaela for the younger patients, and then Tracy, perhaps you might have some thoughts for the older boys.
Yeah, I think that again, I'm always reluctant to invent new treatments. So we already know little about vamorolone, and I think that starting different combination will be totally not based on any clinical evidence. So vamorolone is a steroid, and therefore outside the context that Jared explained, that is with which we might need to have a period when we associate vamorolone with hydrocortisone, which is another steroid, and is for a specific aim. So hydrocortisone is really to come to address the issues in terms of adrenal insufficiency, and therefore there is the rationale. But otherwise, starting with vamorolone associated with the prednisone or the deflazacort, there is no real justification, and you actually run the risk to either overdose with the steroid and therefore have more side effects without really having a clear benefit from the association. So I think that it's a learning process, but I think that is one thing that we should have learned from classic corticosteroid. I always want to remind people that when we started using classic corticosteroid in Duchenne muscular dystrophy, there was a lot of unknown. And maybe now we are in a similar situation with vamorolone, that there is a lot of unknown, but fortunately we have an alternative that we know very well. And therefore is more, if the decision is made that it might be in the best interest of the individual person to switch to vamorolone, there is always the consideration that we can switch back to classic steroid. But I would avoid to start to have individual treatment and personalized mixing of drug, because there is a potential risk.
Thanks, Michaela. Tracy, any thoughts?
Yeah, similarly, I'd be, I think, the reason why we did, sort of the trials and, the 4DMD was try to get that optimum regimen and, sort of to get that standardization of treatment. And I think, mixing regimens and mixing things just muddies the water. And as a clinician, you find it very difficult then to actually manage your patient and potentially putting that patient at risk. I think what we've got to remember as well, this is very individual, and some patients respond really well to steroids and some don't respond as well. So you will always have a little DMD boy that you'll start on a steroid, and actually they sort of improve dramatically, and then another child who's similar sort of in their presentation, and you start them and actually it doesn't seem to make such a vast improvement in their motor function. And I think, sort of, as Michaela and Anne-Marie and Jared have said, I think this is going to be a big learning, curve. And I think we will need to very carefully collect that data so that, 5 years down the line, we will have more information then and be able to advise our newly diagnosed Duchenne patients, with a bit more information than we've got now.
Thank you so much. We've got time for a couple more questions, but before we do that, I was going to go to Neeru and John just to ask for your thoughts. Neeru, do you want to go first?
Yeah, of course. Thank you. So I'm Neeru. I work at Muscular Dystrophy UK. With some of the questions that have been asked, we get very similar questions to our helpline, and we do direct people back to their clinical teams. But I think I'd just echo what you've all said. It's a huge step forward in terms of the availability of a different treatment option, a different type of steroid. But there's questions, there's uncertainties, and we're hearing a lot of that from the community. So it's been great to have clearer information here. But yeah, and it's been great to be here and listen to this. And our support service is always there to support people and direct them to the relevant teams to get the right information. But yeah, I would just echo what's been said. Thank you.
Thank you so much. John?
Thank you, Emily. Yes, hi, I'm John. I work for Action Duchenne. And again, thank you to Emily and Kathy and the team for putting this together. It's been very, very helpful, and to the clinicians who have given us a very informative set of talks. I would again sort of reiterate what Neeru and others have said. We received a number of questions regarding eligibility, sort of risks, pros and cons associated with this. We're always advocating for access to new treatments, and I think having a new treatment available as no treatment is a one size fits all. I think it's a step in the right direction. I think what we've seen from the community has been some sort of cautious optimism. I think the caution sort of comes from people not being sure sort of how the practicalities of switching from one to the other will work and the risks associated with them. But I think the information you provided today has been really useful to be able to answer that. So yeah, thank you very much. And again, we're always here to support and help the community.
Thank you both so much. And of course, this webinar is being recorded, so it can also be shared after this evening. One question for you. Can patients start Vamorolone and then start Givinostat soon after? Michaela?
I think that there is, I think the answer in brief is yes. I think that it will be obviously on a case by case. And one thing that I think that is important to remember is that might be recommended from a clinical point of view not to start two new medication at the same time, because obviously if someone experiences side effects, you want to understand which drug is causing the side effects. And although the side effects profile of the two drugs is different, it's always better to do it one step at a time. So most of the clinicians might ask for a window in between, but there is no rationale not to be able to prescribe both drugs in a subject.
Well, I think that's a positive note to end on, Michaela. So I'd just like to thank Adam and Kathy Turner.
Sorry, Emily, can I just do to point out just as before closing, is first of all, yes, there are some more evidence that we are expecting, and therefore we'll try to keep the community as informed as possible as soon as more evidence will become available to us and therefore to everyone. And one that was mentioned in one of the on the question is obviously we are also working in order to compare the 4DMD data with the Vamorolone data and use what the community has contributed to generate to answer question. And also that as part of the DMD Care UK, as Jared already mentioned, the Bone and Endocrine Working Group has really put a lot of effort to develop some guidance for clinicians and for patients on the management of adrenal suppression on patients on Vamorolone, and we are working with the steroid working group and more generally with the North Star network in order to release some guidance about corticosteroid, including Vamorolone, both for clinician and patient. And these will be released in the upcoming weeks and hopefully will answer some of the questions that we were not able to answer today.
Thank you, Michaela, and for picking up on the 4DMD question, which was a very good question. Kathy, do you want to say something?
Yes, thank you. Just to echo, thank you to all the speakers tonight and for everyone who joined. I just wanted to say apologies if we didn't get to your question, but I will go through them and try and respond to people. Not myself, I will get the experts to provide a response and then send it on to you if we didn't get around to your question. And if you need anything else after this webinar, any more information, we can you have my email address, so you can email me and I can send you the summary of evidence that we've circulated and so on and so forth. So thank you.
Thanks so much, Kathy. And again, thank you to you and Adam for organising it. And a really big thank you to Anne-Marie, Michaela, Tracy and Jared for giving us your time and your expertise to put together such a useful and helpful explanation. So there's a lot for us as a community to get our heads around. We do have some data, we don't have all the answers, but rest assured that we are doing everything we can to get those answers. And thank you all very much for listening to our webinar on Vamorolone.